It is my pleasure to be up here today, and it is quite a challenge because it's very hard to do a talk after the very high level of intellectual knowledge, enthusiasm, and just the discussion that's gone by. And I feel a little vulnerable because if I would be doing this talk by myself in a dinner meeting at night, I'd have no problems. I could slam it out. But in reality, this is a talk that is following and contains a lot of the information that you've already heard. And I don't want to be redundant before lunch and repeat content that you've already heard. And so what I'm going to try and do as I go forward in this talk is to really cherry pick out of the talk what I think is relevant to me in my day-to-day practice. Because there is no question there's two streams of how you utilize MRI and ultrasound in the world of rheumatology. There is absolutely the high level, 10,000 feet research studies and a utilization that really doesn't have bearing in the real world, where we need to understand how to utilize these tools for the management of our patients, for their best interests, and we also have to balance off the costs, because one of the biggest problems we have is we're on a day-to-day basis, and all my clinical colleagues in this audience are sharing the same pain at the moment. We have to justify why we're doing anything, whether it's a diagnostic test or a treatment. And I believe that these tools are critical in making treatment choices as well as in justifying what we're doing. So I really feed on what has happened to this point in terms of what we've heard, and would like to try and kind of use that to piggyback into my talk, with the understanding that obviously some of the information may be a little bit repetitive, but hopefully you'll look at it from a different angle. I think this slide really points out the explosion that's happened in rheumatology, and I always look at osteoporosis as the simple diagnosis, where the advent of bone density really increased awareness. So we had a diagnostic tool that increased awareness that changed therapies. And I believe rheumatoid arthritis and osteoarthritis and psoriatic arthritis and ankylosing spondylitis and gout and on and on and on all fit into the same paradigm. And that's what we're treating all day long. So for me, the utilization in an interreactive fashion of a diagnostic tool to help me choose my treatment, make an early diagnosis, all go hand in glove together to ultimately achieve the best outcome for our patients. We've already seen from an inflammatory point of view that the use of MRI has made a huge difference in the spondyloarthritic conditions, whether it be AS or PSA. Rheumatoid arthritis, the predictive value for the development of the disease at onset. And osteoarthritis, which is lagging a little bit behind, as Philip mentioned, certainly diagnostically, but I'm hopeful that even though it may be lagging behind, that it's going to be one of these horses that kind of like, takes a little while to make the turn, but it's going to end up in the front at the end, because it is ultimately the disease that affects the majority of people in our population. And I believe that at some point in time, the treatment is going to catch up, and really it's going to catch up because of the diagnostic tools that we utilize. So getting into the RA arena, and this is an article from Joseph Smolin, where the point of this study was to look at the fact that we recognized that DAS remission really wasn't very satisfactory to many people. And they did the study and they showed that in DAS remission, DAS 28 remission, you still have swollen joints. So there's something wrong there, and I tell you what's wrong is that DAS 28 remission wasn't remission. And we're going to see that again and again and again when we ask ourselves, why is there a clinical disconnect? Because as much as rheumatologists treat patients by Gestalt, I truly believe that they know when their patients are in remission in a far more accurate fashion in the practice environment than when we do a DAS 28 and we see patients still having swollen joints and we say we've achieved a good enough outcome. So we see that in that particular report, that swollen joints were the driver of joint damage in patients who were supposedly in DAS remission. And then we get into the studies that have been kind of showed up this morning, and obviously this is one, probably the most important study that was published by Philip's group, because it really was probably, to my mind, the first time that I was really made aware of this disconnect between clinical remission, and continued structural deterioration. So obviously they basically had their explanation, or they didn't really have an explanation as much as an observation. The observation is that clinically we aren't that good. We aren't that good, certainly utilizing what was considered in community standards a remission. In fact, we see that in the majority of the patients who were in remission, there was a continuation of basically disease activity in these patients with rheumatoid arthritis. And in that particular study, the interesting thing to me, and I'd like to hear Philip's comments later on, was that the power Doppler signal was really a significant predictor, as was synovial hypertrophy. But as we see in this very busy slide, but if you can just zone in on bone marrow edema, the bone marrow edema here did not have much predictive value at all, if any. And I raised the question whether it was because these patients were more mature patients, as Philip just mentioned in his question and answer session, whether these patients were in fact beyond that so-called window of opportunity, that early treatment phase where edema may have more role. So I think what we see here is obviously synovitis and bone marrow edema at different phases in the disease may have different implications in terms of where the disease is at and what treatment possibly we should be utilizing. And so if we look at a number of different studies, and these are all in your syllabus, and I'm not going to really go into them in depth. Certainly you're free to kind of ask any questions on them. But the point of these studies, as you look at them again and again, is that despite using different outcome scores, whether it's an ACR score, an SDI, a CDI, or a DAS28, remission clinically is not going to basically give you the comfort that you can actually walk away from your patient and say you're going to be fine. We see that progression of disease continues to occur in anywhere from 20 to 40% of patients. Here we see another study that was more recent from the same group that was just published last year in 2011, and it's kind of similar. You see DAS28 21%, ACR 15%, SDI 19%, and this is a study from the Brigham as well as Salim's study where we look at joint damage continuing despite remission. So I think before I move on to this next talk, if you were an oncologist and you saw that data, you would have no doubt in your mind that when you're treating your patients in your office, you can't say, you're feeling good today, you look good today, I don't feel any lymph nodes, see you later. No oncologist in their right mind would do that. So why, as rheumatologists, and this is the 5th year in a row we've had this conversation, are we still struggling to understand the fact that whether it's an MR or an ultrasound or both, and I'm not going to tell you I know which one necessary to utilize. I think that in my practice there's probably both being used at different intervals. We know ultrasound is much more practical. You can put it on the joint and look at it. MRI takes more of a process. But regardless, for you to make treatment choices in your practice, both step up and step down, you need something more than just being able to look at your patient. And any oncologist in the world would agree with you. And unfortunately, I think in our profession, we haven't reached that point yet. So I agree with Maria's point and Mikhail's point that we need longitudinal data and we need to do these studies. The problem is I've got patients in front of me tomorrow morning and they want me to treat them in the best possible fashion. And so there is this disconnect where, I mean, I don't want to do something wrong. I don't want to over-treat, but I am faced with this question as to when do we treat patients and when do we step up or step down. And I believe that we do have a lot of information and evidence, and I'm kind of frustrated and impatient because right now I believe it's taking too long for the consensus to come around to where ultimately, if you look at the oncology model, it's going to come around. So we spoke about bone edema earlier on as being, you know, a really great marker, a great predictor. The semester study Mikhail mentioned, and we see there loud and clear that the bone edema was the strongest predictor of radiographic progression after 2 years. So certainly, if we see bone marrow edema, I think we know we need to bring out our big guns. And you know, the question I think that especially in the real world, the payers really want us to exhaust 1, 2, 3 DMARDs before bringing in our big guns. And I think that we need to use this evidence to show that in reality, functional disability is absolutely correlated at 6 years with osteitis. And so that if you do have osteitis and you don't aggressively treat your patient, you're going to run into a situation where the cost to the system, the cost to the patient, and the eventual outcome has significant implications from both a morbidity and a mortality perspective. You saw this slide earlier on from Jimenez-Bourget, from Smolin's group, in terms of what it means. But I want to re-emphasize it, because I think what's lost is that the MRI, looking at bone marrow edema, is the keyhole into this disease. We actually have the ability to look at this inflammatory cell infiltrate. It's like looking at a cut on the skin. It's like looking at a wound. And this is something that we somehow or other have put blinders on as to not necessarily this group, obviously, but not recognizing the importance of using this to help make treatment decisions. And so we see a whole bunch of references that relate to the value of bone edema and the fact that it's got these inflammatory cell aggregates into it. And actually, what I found really fascinating, and Philip said something that I also was kind of like, maybe I didn't necessarily agree with, but that we don't necessarily see a disconnect between synovitis and erosions and rheumatoid arthritis. Because in my mind, maybe we don't see a disconnect, but because we see these things at different time spans, that they don't occur together. So we have some patients who have proliferative synovitis and don't seem to have the same erosive potential as other patients who you're kind of surprised that the erosions are as severe as they are in the absence of synovitis. Now, Fiona McQueen spoke about this disconnect, and I mean, she kind of like sort of diagrams it this way, where she, I think, kind of like asks the question, is it because the diseases are different? Are there in fact different cytokine drivers that are driving either synovitis or osteitis? And that's a really important question, because that may help us make a decision as to what treatments to choose. We've historically used TNF1, TNF2, TNF3, because that's how the drugs came to the marketplace. And what's happened is that all the guidelines suggest that we should use TNFs 1, 2, and 3. But in fact, is that correct? If we see a patient who's got more osteitis and synovitis, and that is a B-cell modulated disease, would we not be better off saying this patient, in fact, would be better off with a B-cell modulator rather than a TNF inhibitor? And I raise that question because in the real world where we're treating patients and the cost of these drugs are so high, I think we're ignoring evidence, or what's happening is that the pathways that have been created by people who have not really looked at the evidence to this extent are telling us how to treat our patients inappropriately. So it's a question. I'd like to also point out, and I agree once more in the slide, that the use of zoledronic acid, denosumab, is something that may in fact help, those drugs may in fact inhibit rank ligand, and that may in fact either inhibit erosions, or we may actually see some early erosions reversing. You know, it's kind of interesting. There are articles in the literature that do talk about some degree of reversibility of erosions, and whether those erosions were erosions in the first place or whether they were just significant clumps of bone edema, I'm not sure. But we wonder if combined therapy would not be something that would be more efficacious for our patients when you see synovitis and osteitis over there. So we see a lot of references there to the presence of edema and synovitis as outcome scores, and we talk about how obviously we see again and again, and we look at the literature, one paper after another. This one's from Paris, and we basically see that subclinical inflammation is something that we should be conscious of when we're basically looking at our patients in our practice on a daily basis. So if we look at how we can use MRI in our offices on a daily basis, I think we can look at it in a number of different ways. Certainly early diagnosis, and we've seen, and there's one reference to a paper over there from Denmark, where in undifferentiated early inflammatory arthritis, the presence of erosions and osteitis absolutely predict that these patients are going to evolve into rheumatoid arthritis. So early diagnosis, allowing you to be possibly a little faster in your treatment choices. And then monitoring your patients. When your patients have actually got the disease, what do we do about it? And can we monitor the disease? And how can imaging assess the treatment response in rheumatoid arthritis? Because I want you to think about something else. We have not spoken once today about how do you down-treat your patients? How do you take your patient from the biologic and basically reduce it back to a DMARD? We're talking about early treatment, cool. We're talking about being really aggressive, cool. But you're 20 years old, and now you're basically being put on your TNF or whatever biologic you want, and you're sitting and saying, is this it for the rest of my life? Maybe it is. But I don't think that we've spent enough time using imaging tools to help us answer that question. That if in fact you can see imaging remission, whether it's ultrasound or MRI, maybe you can use that as a mechanism to try and obviously in the whole picture, looking at your clinical, your serological, your markers, maybe we can start taking some of our patients off biologics, and maybe we can use it in an intermittent basis. Once we're getting into that oncological model where you have your initial protocol, which includes everything, and then we downtreat, because I think we kind of start slowly, and that's why we never catch up. We continuously chase our tail, and then when we get there, we're too scared to reduce the drug. And if you look at the cost of being on one of these drugs for 40 years, which is essentially very feasible now. I've now got patients who basically are on their 132nd Remicade infusion. And if you add up what that costs to whoever's paying for it, it's astronomical, not to say not very practical. So the next 3 slides which are in your book, and I'm not going to go through them, but it kind of shows you how the paradigm of RA has changed. Up until 96, we basically waited for erosions and basically disability to occur before we jumped in with cytoxan and plasmapheresis. We got a little bit more hip when the biologics came out, but nevertheless the guidelines were still telling us, you know, let's look at erosions, let's look at loss of joint space before we really get into using drugs, or we switch from TNFs to whatever. And I'm saying right now, looking forward, if we look at our ultrasound and MRI findings, I believe we can make early diagnoses, early treatment, and what we should be doing, we should be utilizing these findings to help make treatment choices that may in fact allow us to switch to different mechanisms of actions, or actually even downregulate the type of treatment that we're utilizing. And I believe that when you go in front of the payers, if you can actually use this argument that, hey, you know what, I want an MRI because maybe I can stop the drug, we'll have a much better chance of getting them to go along with us than if we go to them saying, I want to use the MRI because I want to add a drug, which doesn't sound very good to them when they hear that argument. So, let me switch to osteoarthritis quickly. What I want you to recognize is that rheumatoid arthritis only occupies 20% of our lives at best. So, you know, I'm always asked, should I put an MRI in my office? And it really doesn't boil down to how many patients with rheumatoid arthritis you've got, because it'll never sustain putting an MRI in your office. And I know from being in this field at the very beginning, everybody focused on the value of MRI for rheumatoid arthritis. And we had some very early primitive MRIs that really, you know, were, as we know, with the MagnaView devices, they didn't last very long, but they opened the door for us. But they kind of conceptually made us, I think, they took us down the wrong pathway. They sort of implied that for rheumatology, the only reason you need an MRI is for rheumatoid arthritis. In fact, that's the very small part of the kind of patients you're seeing in your practice. So let's look at some of the other diagnoses that you are seeing on a much bigger day-to-day. So we look at osteoarthritis, and probably we all see 10 of these patients today, someone coming in with pain in the knee. And you know what? The MRI is a darn good tool to diagnose what's going on in the knee. And if you look at the value of edema, and once in a while I was kind of, you know, listening earlier on when we spoke about, well, if you go gardening or jog, that the ultrasound can show you some kind of increased activity in the synovium. Well, you know, bone marrow edema in the knee for someone who is a jogger is not a very good prognostic sign. And if you had that patient in your office, just telling them, look, if you're going to go on jogging, your knee is going to collapse. And I think that we need to understand that the value of an MRI is to show patients what's going on, to help them understand why their pain is there, and obviously to make a diagnosis to make sure that what they've got is not a torn meniscus or whatever, which you'll obviously see very well on your MRI. So the consensus statement that came out of ORSI with regards to MRI is that, you know, MRI changes in osteoarthritis may occur in the absence of radiographic findings. So once more, we're seeing that there is a value to seeing an MRI in a patient who's complaining of pain in their joint when in fact the x-rays may not yet have changed. It may add to the diagnosis of an OA and should be incorporated into the ACR diagnostic criteria. MRI may be used for inclusion in clinical studies, but should not be a primary diagnostic tool, so we agree with that. And obviously, certain MRI changes in isolation, whatever they may be, are basically not necessarily diagnostic of OA, but are diagnostic of what the patient is in your office. So forget about research. Patients in your office complaining of pain, and if you basically find out that they've got a ligamentous or tendon damage, you've done them a lot of service. So I think from a rheumatology point of view, from a perspective of someone who does a lot of medical orthopedics, there is incredible value of being able to do this in your office and give patients the idea of the fact that this is your diagnosis. You've got a meniscal tear and so on and so forth. This was a study done on the hand. I'm conscious of my time and I don't want to basically, beat this to death, but even in this particular study, we see that the presence of osteophytes, the presence of synovitis, tenosynovitis, and even bone marrow edema is something that you're going to basically see to a far higher percent that you'll ever see, or you won't even see, period, on x-ray. So there's a significant value of doing that. When it comes to articular cartilage, the area that, once more, that was touched on, that I think is really fascinating is most of us in the US are now basically looking at the use of viscous supplements, and we're questioning, are our patients responding? Are they actually responding, as once more Philip was saying, he thinks it's because of the lavage that these things do. I don't know what the reason is. Are we doing anything to the articular cartilage? Well, I think that we absolutely should be looking at the articular cartilage and determining what kind of treatments we can choose for our patients as we move forward. And we see in this particular study that in this particular case, T2 mapping was a repeatable process that showed differences between the OA patient and control groups. So there is no question that there is value to looking at these things. I think this is probably a little bit more, once more, pre-market so-called research orientated. But in our offices on a regular basis, I have to make the decision in some patients, do I do viscous supplement or not? And I know that this does help me a lot. Ankylosing spondylitis, ruling out the causes of back pain. We as rheumatologists see this all day long. I think you all know the value of an MRI with sacroiliac disease, and so that's something that in a very significant number of patients, we know that this is something that we can basically measure now and help us distinguish the different causes of back pain that we basically are looking at. Let me go into the psoriatic arthritis conversation, which was really already discussed this morning, but I think from my perspective, just to try and kind of enhance the conversation with psoriatic arthritis, where I see the biggest value is not so much in the clinical diagnosis other than maybe with enthesopathies, but it certainly does help us see what's going on with the synovitis, the damage to the joints, and once more helps us in our treatment choices, because I think we know how rapid the destruction in psoriatic arthritis can be. And I think if we see that osteitis and the synovitis present, we should be reaching for a biologic far earlier than probably historically we did with these patients, where we tended to push the dose of methotrexate to the point where joint destruction occurred before we really knew what was happening to us. So that's in your books, and you can see the value of looking at psoriatic arthritis over there, and we've already discussed most of this morning. So now I'm going to get into maybe what you were waiting for me to talk about is, MRI in the office. And I'm not going to get into this office planning unless someone specifically wants to, other than to say, is look at your patient demographics and look at your office. You can put an extremity MRI in your office with very, very little work. You don't need lid walls. You need to have a quiet area where you're not basically going to have noise interfering with your ability to perform the studies. You absolutely need to have a legitimate MRI technician. Aaron is going to talk to you about what actually is required for an MRI in your office. You need to do a financial performance. Make sure that you have enough patients. Probably my recommendation is that you're going to need to do a minimum of 3 patients a day to make this productive. So if you're only seeing 6 patients a day, you probably shouldn't be thinking about an MRI. But if you've got a practice that's seeing 30 patients a day, to me, you really won't have a problem. The other thing you do need to look at, though, is your patient mix, because if you've got 75% of your practice is managed care, you may struggle to get them to allow you to do the MRIs in your practice. So you do need to consider these things when you go into this venture and determine whether in fact you have the actual requirements both from a physical as well as from a payer perspective to make you make that decision. The comparison between low field versus conventional MRI is listed there. We've discussed this at previous meetings, but I think from the perspective of what you're going to be utilizing it for in your practice. And Stephen Adele, when he gives his talk, always shows the picture of the Mona Lisa that's a little blurred. From our perspective, we have enough value in a low field MRI to pretty much make all the diagnostic and treatment decisions that we need. We're not looking at dendritic cells in the brain. We're not looking for demyelinating lesions. So the reality is, if you look at the literature, there is absolutely excellent support to consider that you basically have diagnostically equivalent value between a low field and a high field. Now, there are some situations that the low field will not work, and that may be more physically than actually what you're actually looking at. And so let's just look at the indications in your practice that you could basically find for you to do an MRI. And listed there is essentially from head to toe the different diagnostic categories that would basically at some point in time probably need, not benefit, but need an MRI to basically determine the state of their disease. I look at the one thing that stands out to me is epicondylitis. I'm sure you've all had that resistant case of epicondylitis. You've injected it, you've splintered it, you've anti-inflammatory it to death, and the patient's still got pain in the elbow, and you can't figure out what's going on. You do an MRI, and there's a flagrant tear of the medial ligament. So a simple example that I could go down this whole list and show you why the MRI is extremely valuable, and you're probably doing it, except you're sending it to the hospital down the road. And wouldn't it be nicer to do it if you could yourself? So this is in my particular practice where we have, this is a low field 0.27 Tesla EMR, which does everything except it cannot do chests and bellies, doesn't do brains, but it does everything from a musculoskeletal perspective. And the reason we put these pictures there is just to show you the look of the machine, the complete openness of this MRI, which is very, very desirable for the patients, and why it also sometimes isn't very adequate. I mean, to ask this gentleman to hold his breath for 45 minutes doesn't go down so well. So it does have its physical limitations for patients whose girth is too wide or whose weight is too much. But we see all the different extremities going on over there. So the capabilities are listed there, as I said, from head to toe. The strength, really you can get as much as you really want, but obviously there's a cost to getting a higher field. So the lower field strength is probably much better. We mentioned the limitations. And this is just looking at some of the diagnoses that you will basically see in your practice that will be diagnosed if you have an MRI. And we look at osteonecrosis, we look at maybe a pigmented villonodular synovitis, stress fractures, very common in our osteoporotic elderly patient population and really very easily diagnosed by MRI. The causes of posterior ankle pain, if you have anybody who does foot and ankle in your practice in particular, I mean, they will basically tell you how valuable this is to make a diagnosis for them. So pretty much, on and on here, I'm showing you actually the meat and potatoes of why you would utilize an MRI in your practice rather than talking about rheumatoid arthritis, which is obviously the intellectual side of it, but the truth of the matter is, it is what I'm showing you here now in a relatively rapid fashion. The real reason why having an MRI in your practice may make a lot of sense. Obviously, you can see very, very nice pictures of the hip and spine over there. And so the conclusion to all of that is that EMRI is a very proficient tool at assessing a wide spectrum of non-arthritis related pathologies which may be routinely encountered in the practice. So I've gone through that, I think, in a pretty fast time. And I know I've covered a lot. I think the bottom line is, hopefully, I've given you a taste of why it's kind of fun to have an MRI in your office. Thank you. Oh, by the way, the diagnostic codes for everything that are here are all listed in your syllabus, so if you want them, they're there for you.